Thank you very much, Sue, and apologies that I have to rush off. The challenge will be the 10:30 train to Houston because of the Royal Society of Medicine is running a day on patient safety in maternity. And because we're running a bit late, apologies if I sort of have to run through some of the slides more quickly than otherwise. But essentially, as Sue already said, we are the Perinatal Institute, formerly West Midlands NHS. So welcome to sunny Birmingham, those of you who traveled. And we are dealing with a number of issues which are in fact represented here relating to, for example, our SCORE program, the National Handheld Maternity Notes, MyApp, the electronic maternity record, and I'll be talking about fetal growth restriction. The team is there in stand 22. Please go and see them. I think it's just to the left as you go into the big hall. And one of the issues will be a demonstration by Angela here on the MyApp, and she in fact is talking later on seminar 6 at 12:25, so I suggest you try to get along to that one. We also have a few posters up which relate to the standardized clinical outcome review application, a tool that we've applied to perinatal deaths, as well as to near misses, small for gestational age babies that are not recognized antenatally. We also have a poster from Sally Buller as well as Sally Giddings on the diabetes in pregnancy, as well as postnatal bereavement notes. Which brings us back to the topic of this talk, which is stillbirths. Has recently been highlighted again by the Lancet, the importance of trying to move towards prevention. We here in the West Midlands had more reason than most to try to do something about it. The stillbirth rates have been more or less constant over the last 20 years, and in West Midlands have been consistently above the national average. And 10 or so years ago, when we started to address this issue, one of the problems was that most of them were designated as unexplained using the old Wigglesworth classification. Recently, Embrace's Kodak classification regrettably still continues to classify most of them as unexplained or unknown cause. The latest report was nearly 50% were that, which is not very helpful for mothers. Here's a mother blogging or reporting on her loss, and you can see from her telling this horrifying experience and sharing it with her husband. And then she's being told about 50% of stillbirths are not explained with no clear reason why they occurred. And that really, and here's what she says, that really annoys me. There was a reason, at least, we'd know what to watch out for in the future, but because it's unexplained, why did it happen? Was it missed? Was it my fault? Was it medical negligence? There's absolutely no reason for it. So there's all these questions that then come flooding in, and it's really difficult for mothers also to come to terms with the loss if they do not know what has happened and why tomorrow. And of course, it's not helpful for clinicians when they're trying to understand what has happened and how to prevent the next one from happening. In fact, one of the things that you notice when you plot stillbirth weights against gestation, that many of them, in fact, are babies that have not fulfilled their growth potential. They are much smaller than they should be, but also that many of them are, in fact, dying at gestational ages where they would be mature enough if only delivered in good condition. So we applied a classification system that includes fetal growth restriction as one of the categories, and then immediately you see how many of them, in fact, are due to fetal growth restriction. And when we looked in the West Midlands at risk factors for stillbirths, we found that having a baby that is growth restricted increases the risk of stillbirth sevenfold, and it increases even further if it is not recognized antenatally. But if it is recognized, then it significantly reduces the risk. Not to zero, because not all of these babies can be delivered, but significantly less so. And in fact, that reduction in risk occurs at the expense of only 10 days on average earlier delivery, at 270 days instead of 280 days, which means that these babies are not necessarily born prematurely, 270 days, of course, being at term, which starts at 259 days. Now, the reason for that is that, in fact, many of these growth-restricted cases in fact, represent late-onset IUGR. We all know about the severity of early-onset IUGR with severe placental disease, sometimes preeclampsia associated with it, and frank hypoxia. But in many instances, the baby just outgrows the function of an incompletely functioning placenta. And it's a more subtle hypoxia. And that's where good clinical care all the way through pregnancy until delivery by the primary care provider, of course, the midwife, is required and necessary. And in fact, when you look at it, about almost two-thirds of deaths occur at what we would call late onset growth restrictions, starting from, let's say, 30 to 34 weeks onwards. And when we did our confidential inquiries into antenatal, intrapartum, and neonatal using proformas, or in fact the score system, which is on display here as well, which fosters blame-free objective assessment, trying to identify substandard care and derives a taxonomy. When we looked at that, we found, in fact, that most adverse outcomes were associated with substandard care, and up to about 60% were potentially avoidable. And the issues time and time again were the importance of upstream causes, poor antenatal risk assessment, and failure to identify and manage IUGR kept coming up as a main theme. And that is also consistent with Embrace's report last year, looking at confidential inquiry of term stillbirths, where you can see about 60% were considered to be potentially avoidable. So because of that, we sort of started an initiative, a campaign to try to improve the antenatal recognition of fetal growth restriction with standardized fundal height measurement, plotting on customized charts, serial scans for high-risk pregnancy, and then the appropriate protocols and referral pathways. So fundal height measurement really needs to be, so can I just ask, how many of you are working in a unit that is already in the GAP program? Great, so just to summarize what the program does is to make sure that we have a standardized way in which to measure fundal height and that is consistent. And once you do that, once you have workshops on that, like for example here, Joyce and Karen, who worked in New Zealand, who came to sort of train here with us and are rolling it out there, when they have a workshop at the beginning of it, the measurements are, as shown here in the red bars, and they're all over the place. Whereas after the workshop, the same clinicians, midwives, doctors, have got these sort of green bars, and which in fact are over 90% within 1 centimeter of what the measurement actually should be, the gold standard. So midwives already seeing, according to NICE guidelines, mothers serially all the way through pregnancy. It's logical that in addition to assessing the mother and her social and medical and mental health and domestic situation and everything else, to also look at the baby and make sure that it's growing well and to plot it serially. And we plotted on customized charts because they are personalized and adjust for constitutional variation. So for a measurement here, for example, for Laura Tall is small, and for Manjit Small is normal, and you can reassure her. More importantly, you can do serial measurements to sort of, because the chart shows what the normal velocity should be. And even if it is within normal limits, a velocity like this should be a cause for concern. And even if it's above the 90th, if it is following this velocity, then there should be cause for reassurance, but continued monitoring. But when it's accelerated, then consideration needs to be done, needs to be given for further investigation. So there were a number of studies that actually showed that this actually is better than what we used to do in the past. And then a number of studies have shown by us, but also independently, that there is a stronger association. Doing this serial measurement and plotting increases the detection of abnormal growth, but also importantly reduces false positive diagnosis of abnormal, thus normalizing pregnancy. And so the other part, of course, of the protocol is to make sure that the babies in pregnancies that are at increased risk have got scanning, because you start with history and identification of risk factors, serial fundal height measurement, and then referral for ultrasound biometry. But if there's increased risk, then these mothers need scanning all the way through. So again, the customized chart comes in handy there, because when you, for example, plot an estimated fetal weight, which is right on the 50th centile for this lady, whereas it is below. So here it is reassurance, and here it is action. So from a baseline of 18% over the next few years, we found that the antenatal detection of small for gestation is increased rapidly, in particular in the good units where there was a lot of training, and it was very much training dependent. And so the question was, well, how did this affect the actual perinatal mortality rate? And in the West Midlands, as I said, it was consistently above the national average. And then for the first time in 2010, 2011, we found that it was coming down and in fact dropping below the national average for the first time ever since records began. And we knew that this was not due to anything else, all the other causes, but specifically due to reducing stillbirths with fetal growth restriction, which was the sort of most avoidable cause of stillbirth. And when we looked at 30+ weeks pregnancies, here you can see the stillbirth rate compared to the previous average reduced, whereas the neonatal deaths from 30 weeks onwards did not increase at all, so it was reassuring for the neonatologists. And this continued, so that in fact the stillbirth rates in the West Midlands, these are ONS figures, were just dropping and compared to the rest of England and Wales. But then other regions picked it up, and some of you will know because you're from there, Yorkshire and Humber and North East, and in each one of them they invited the team, their units were trained, and you could see that their stillbirth rates dropped as well. Whereas in other parts of the country, which were less enthusiastic at that point, there was no change in the stillbirth rate. So this was a single most powerful way, other than doing a randomized trial, which would be really unfeasible because of relatively rare outcome of stillbirths, but implementing it across regions. You can see that London, Northwest, Wales and the other regions had no difference because they did not do anything at the same time. So when we published this in the BMJ Open, we were able to conclude that this is actually causal association. Nothing else has happened over this period of time, but the introduction of the GAP program, which is what caused the reduction of these stillbirths according to the ONS figures. So we always welcomed the publicity, not so much because of, this highlights our work, but because it highlights our work in terms of against anything else that is relevant and important in the NHS, because maternity needs to come up higher in the agenda. And even we had a panorama, and I always show this slides to embarrass Sue because she was actually there live measuring and showing how it is done and how we are rolling out the program. So there was finally light at the end of the tunnel, and we felt we've got a system which we can actually roll out across the whole country, and that's the growth assessment protocol. Those of you who already know it are aware of it, and it includes comprehensive training, e-learning, competency assessment, protocols, the growth software, but and the training, of course, is a rolling program. So you can see from our website that in fact we've got them almost fortnightly, and they're really quite popular, people coming from all over the place. Occasionally we also go out to train trusts and units. So we are now actually in place in over about 74% of trusts. In fact, it's more than that. This is a bit out of date. And we have sort of moved to monitor detection rates as a really important performance indicator of the service. So that actually happens. It's really very important. And those of you who are in a trust that are doing the GAP program, please make sure that it is also done. It's just that extra little bit, few minutes after delivery to enter what the birth weight was, what the gestation was, but also whether there was antenatal referral, whether there was antenatal detection, and then it calculates whether the baby was SGA or not. And as a result, you can get back your own figures for your own trust, and we can analyze for all the trusts that are doing. And so this is the latest in terms of pre-training and post-training. There's a significant increase in antenatal referral for babies that were then subsequently born SGA, and significant increase in antenatal detection of babies that are born SGA. So it's going in the right direction, but more needs to be done. As a result, also now nationally, we can say that there is a significant reduction in stillbirth rates from the previous 10-year average. It's dropped down to 4.65, which actually represents 500 stillbirths per year. That's about 10 babies fewer dying each week. And so when you look at the GAP program and how it has increased in England over the last few years, it mirrors the drop in stillbirth rates, and we claim that this is what it is until somebody else thinks of something else magical that has happened at the same time. We can make a difference. And as a result of it, Sue mentioned, we got patient safety awards over the last 3 years. The last year's BMJ award was particularly poignant because, in fact, it was the senior judge was Professor Sir Bruce Keir from the NHS. So this whole program becomes part and parcel of it's recognized in terms of the importance for the NHS. And then this year, I don't think that it is up to date yet, we're pleased to also receive a Queen's Award for Enterprise. And in fact, the award is being awarded next week for the GAP program. So, so far so good, but rather than resting on these laurels, which really were due to all the effort in all the trusts that have implemented GAP, over 120 trusts now across the UK, we feel that much more needs to be done, can be done. So the glass is not half full, it's half empty. We feel we can save twice as many babies by more thorough implementation. There are still babies dying unnecessarily. And one of those things I would actually, again, suggest you look at the poster that Emily and Sue will be there to discuss with you when we do a missed case audit. So this is part of the program now, where every 6 months, at least 10 or more missed cases of SGA are entered into the GAP score application. And Sue and Emily have done this across the north of England with a team of designated clinical midwives who then implemented it in their local practice. And in fact, the first results of this suggest that many of the missed cases are because of high-risk cases not getting serial scans, or they had scans but still it was missed, or they were low risk but were referred and it was still missed. And only a quarter of the cases were in fact those where they had fundal height measurement and they were not referred. So we really need to focus in on a better scan provision for these high-risk cases. Now we're hoping that part and parcel of the NHS England care bundle, which highlights monitoring of growth as one of the most important elements of it, that this will make it easier from commissioners to get the adequate resources. There's an algorithm which shows that low risk should have serial fundal height measurement, high risk should have be designated through these risk factors. One or more of these risk factors should then have high risk care or increased risk care, which means serial scan all the way through. Now, a lot of units are struggling with that. How many mothers in the West Midlands would have one or more of these risk factors? Well, depends whether you include smoking or not. The cumulative overlapping frequency is about 22%, and then another few percent for smoking, and total more than a third would need to be allocated for serial scanning. That is really probably too much for a lot of units, so more resources need to be put aside for adequate ultrasound provision for these cases. So both the Green Top guidelines and the NHS England Care Bundle recommend that for low-risk serial fundal height measurement and high-risk serial ultrasound scans, but up to delivery. That's really important, all the way through to delivery. Because if you stop your measurements, or if you stop your scans at 34 to 36 weeks, then in fact your detection rate is 36% only. Because of this late onset IUGR, you need to monitor them all the way through till delivery, not stop. So the scan shouldn't stop before term. That's an argument that is being carried out in many units around them. Now, obviously, shortages of scan resources need to be addressed. And one way in which to address it, and we've done this in Birmingham successfully, is the midwifery scanning, a midwifery-led ultrasound service was in the community, and it worked really well, and it significantly increased antenatal detection. But again, that requires resources. So in summary, we've got a strategy for stillbirth prevention through improved antenatal detection of fetal growth restriction. It starts with increased awareness, really very important. These babies are, these deaths are potentially avoidable. Now, understanding the risks, recognizing, managing low and high risk, adhering to the protocols, appropriate tools like the customized charts and the monitoring, auditing what you're doing, and then to implement those evidence-based protocols, both the RCOG guidelines, but also the NHS England algorithm. So I thought I'll stop there, but maybe also just finish with one story, because I'll be seeing her at the Royal Society of Medicine. This is the meeting that I'm sorry I have to rush off to. But this is the story of Heidi Eldridge. You might have heard about her before, because she blogged about her loss, and she was one of the many mothers who get sent home with unexplained as a diagnosis. It's a non-diagnosis. But in fact, when you look at the clue is in fact in her own blog, because it was a 36-week, 5.4-ounce baby. And if you plot that, this is a baby that was growth restricted but was not recognized. It was not recognized antenatally, and then it was not recognized even afterwards when they tried to work out what was going on, so I told her it's unexplained. Not very good for her to come to terms with it, and from the health profession, midwives, doctors, to try to learn from what has happened. So then she just became a part of a statistic. But not her, and not many other mothers, because they want to give something back. They want to try to contribute to prevention. And in fact, the Mama Academy is what she started, and she's joined the Made to Measure campaign, and she's doing lots of great work to try to improve the safety. Thank you very much.
And you have 5 minutes for questions. I've got 5 minutes. So if anybody has a question, if you can raise your hand. We have a roving mic who can run about.
Can I suggest, we've got an amazing team. I showed the picture before. In fact, I will show it again, just to embarrass them again. And they're there at the stall. They know about all of this as well or better than I do, especially the GAP program. They're running it, leading it, and all that. So please go and frequent the stand, and they'll be able to answer all your questions.
Okay. That's great. Thank you very much. No questions?